Well, actually, the ESC Congress is an amazing opportunity to highlight and learn about the new recommendations that have been published. This year we have had 4 new guidelines. One of them is the ventricular arrhythmia ones and the prevention of sudden cardiac death. I'm particularly fond of that guideline. This is my field of expertise, the arrhythmias, including atrial fibrillation and also sudden cardiac death. The nice thing about these guidelines is that it incorporates a lot of new evidence, and it highlights the importance of properly evaluating patients with sudden cardiac death, which is one of the leading causes of death worldwide. There's a very specific evaluation pathway, including new technologies like genetic testing. It's very important to evaluate in case of death the autopsy with specialized pathologists, and to rule out, both in survivors of cardiac arrest and in autopsy, the different possibilities or underlying pathologies in order to prevent sudden cardiac death, both in the patient and in the family relatives. So the guidelines give a lot of guidance in general and also guidance in the specific entities, including ischemic heart disease, cardiomyopathies, primary arrhythmias of the heart, and other contexts where the individuals have a high risk of ventricular arrhythmias and sudden death. Then there have been other 3 guidelines. One of them is the cardio-oncology one. This is the 3rd edition of these guidelines, and this is because there's growing evidence that there is a big relationship between cardiology and oncology, and in particular patients with cancer may have heart disease, pre-existing heart disease, that modify or may modify the prognosis and the treatment of incident cancer, and on the other hand, cancer therapies may be associated with increased risk of developing left ventricular dysfunction or heart problems. And therefore these guidelines are so useful because it explains how patients need to evaluate it both at baseline, namely usually it's just an ECG and echo. From there, depending on the findings, you may need to do some extra tests, and then which medications may affect the heart, how do you follow these patients up, and what should be your management after the treatment, the cancer has been treated and the patient may have had or not concomitant heart disease. Mm-hmm. The 3rd guideline was the pulmonary hypertension one. The pulmonary hypertension is a rare disease, let's say. Not many people or many cardiologists are comfortable or know a lot about this disease, so it's going to be useful for the implementation of evidence-based recommendations. And there have been new therapies in the past few years that have come up for the treatment of these individuals, and therefore this guideline, and that's why this guideline is so useful. And finally, there's the non-cardiac surgery guideline, which is also a very relevant topic because there's so many patients undergoing surgery, any type of surgery worldwide. Some of them are low risk and some of them are high risk, and they may have underlying heart disease, and therefore in order to prevent complication, cardiovascular complication of these surgeries, this guideline is very important. There are 2 patient guidelines, and these patient guidelines are particularly interesting because they have been designed in collaboration with the ESC Patient Forum and patient experts, and this will allow in the field of heart failure and also preventive cardiology, so prevention of cardiovascular disease, they will promote and facilitate the implementation of the guidelines because the patients will understand what are evidence-based recommendations, and they will implement them easily because it's translated to a common population, general population language. Mm-hmm. In terms of research, there have been so many fascinating randomized clinical trials and other types of trials, and the hotline sessions have shown many different aspects. So one of them several of them have had, at least from my conversation with colleagues and on social media, major impact. So for instance, we have the Perspective trial that evaluates sacubitril valsartan compared to valsartan only in cognitive function in patients with heart failure and preserved left ventricular ejection fraction, and this was randomized, and it shows well, there was some concern that this drug could increase the deposit of beta amyloid and decrease cognitive function, and it shows that it's safe to give it because there's no evidence that adding sacubitril to valsartan increases this risk or decreases cognitive function. The SECURE trial is the secondary prevention of cardiovascular disease in the elderly, and it's the concept of the polypill, a polypill that contains aspirin, atorvastatin and ramipril, and it results in a significant reduction of cardiovascular events compared to usual care, and that's very interesting. Another study compared the timing of blood pressure reducing drugs, whether it was better to give them at night or during the morning, and they saw no differences, and this allows us as professionals to choose the better option for our patients with no concern. Then we have other studies in acute heart failure, like the AIDVOR study, which compared the addition of acetazolamide to I'm gonna say the word. Well, the conventional diuretics in acute heart failure, in reducing or improving outcomes in acute heart failure, and it appears to be favorable. The BOX trial evaluated high intensity oxygenation compared to reduced, and they found no differences in the context of cardiac arrest survivors. The DAN-CANVAS study evaluated the outcomes of screening for cardiovascular disease based on cardiac CT and root CT to rule out vascular disease and coronary disease. The comparison of brachial and ankle blood pressure to rule out peripheral vascular disease and blood test, and this was able to identify mainly in a subgroup of patients between 65 to 70 years old to improve outcomes. The overall population, which was 65 to 74 years of age, did not show an overall benefit, so it seems that this benefit is probably in the younger group of patients. Also, we have the comparison, the DAN-FLU-1 study, which compared high-dose influenza vaccination to a regular standard dose, and apparently this high dose reduced the cardiovascular morbidity and mortality. I can continue, there's many more. I don't know if you like me, but we have the ALL-HEART study. It evaluates allopurinol to the addition of allopurinol to prevent cardiovascular outcomes in ischemic heart disease, but this did not show any benefit. Artificial intelligence. We have several studies that have been presented regarding artificial intelligence. One of them was the ECONET randomized trial, where they evaluated the accuracy of left ventricular ejection fraction calculation, standard of care, which is done by sonographers or using an artificial intelligence derived algorithm, and then this was assessed blindly by a cardiologist, and the AI algorithm performed much better than the sonographer guided classification or calculation of the left ventricular ejection fraction. We have the eBrave AF trial, which is a smartphone-based screening using AI for atrial fibrillation, and it shows in more than 65,000 individuals with recorders that using artificial intelligence improve the accuracy of screening for atrial fibrillation and increases subsequently the anticoagulation management. AI has also shown to be better in classifying and evaluating the severity of aortic stenosis, and with this AI-based classification predict prognosis. And also, AI has been used to estimate overall cardiovascular risk by introducing the concept of causal modification. So when you have modifiable risk factors, instead of introducing them as a static concept, using AI, you may modify the effect of treating these modifiable causes, and this predicts better the overall cardiovascular risk in the population. Major other studies in the field, there have been in atrial fibrillation. The Invictus, they evaluated rivaroxaban in rheumatic heart disease, mainly patients from Asia, Africa, and Latin America with rheumatic heart disease and mitral stenosis and high CHASFA score, at least 2. And basically, they found out that vitamin K antagonists are better and have a better profile in preventing mortality and ischemic stroke compared to rivaroxaban, and they didn't increase the risk of bleeding. So vitamin K's antagonists are still the treatment of choice in rheumatic heart disease. Also related with anticoagulation, we have the factor 11 inhibitors. There have been a study, the axiomatic, on milvexian in evaluating secondary stroke prevention, and it's a phase 2 trial, but it shows promise in terms of preventing stroke. Basically, what was found that there was not a dose response, but there was about a 30% relative risk reduction in stroke, and there was no fatal bleeding or hemorrhagic intracranial hemorrhage. So that's very promising. Also in the same field of factor 11 inhibitors, we have asundexian, and there are different sub-arms or different arms of the Pacific study. The acute myocardial infarction one was presented, and also the stroke one, and they also show promising results in terms of being able to be administered in association to antiplatelets in the context of either disease. This of course needs to be validated in phase 3 trials. In the field of heart failure, we have the dapagliflozin in patients with mildly reduced or preserved ejection fraction, and they show as good results as in the patients with reduced ejection fraction. So this is a new tool in this pool of patients that we hardly have any medication to treat them. Then we have the revived study, the revived PCIS2 study, where they evaluated patients with severe dysfunction and extensive coronary artery disease that could be revascularized, and evidence of ischemia. And unfortunately, this study, which was surprising, showed that there's no additional benefit of these patients undergoing revascularization in terms of all-cause mortality or hospitalization for heart failure. Artificial intelligence in atrial fibrillation has many possible applications. During this Congress, multiple studies have been presented. I guess that I would highlight, on the one hand, the one that I mentioned, which is I remember the name, the eBrave AF study. This is for screening, and it's actually a field that it's going to, where artificial intelligence is going to be key. We have now a lot of mHealth devices. So we have the watches, we have the bands, monitors that are able to detect or identify AF. This AF usually, and also based on the guidelines, needs to be confirmed by a 12-lead ECG or a 30-second recording evaluated by a healthcare professional, and so that this artificial intelligence proves to be reliable. It's going to improve significantly the reach that we have to assess all of this health technology that so many people have now at their hands. The other area that artificial intelligence is very promising is personalizing the management of patients. So there have been several presentations. One I would like to highlight is the one on tailoring the ablation therapies to the actual substrate of patients. So in theory, and this, because this is of course in development, if you have a model of the patient's heart and with the appropriate and you identify appropriately the distribution of scar together with other characteristics of the patients which are introduced in the AI model, you can simulate what happens by ablating different areas of the heart and how you modify the substrate. And the aim of this is actually to guide or tailor the ablation therapy to the specific individual with specific anatomic and electrophysiological characteristics. And a trial, a randomized clinical trial, is going to be started in the US, and we'll see whether these results are applicable in everyday clinical practice or not. Not related to artificial intelligence, but in the field of ablation, I would say that also there was a presentation of pulse field ablation, and that is also a very promising technology, which it has a whole different concept. It goes towards simplifying the procedure, finding safer energies with higher success rates with a standardized procedure. So pulmonary vein isolation, achieving complete block and durable block in an easy and safe way. And that's another very promising area in atrial fibrillation ablation.